welcome to our deep dive. Today, we're going to be talking about something you see everywhere in health news, but you might not really fully grasp, and that is the difference between causation and association. It's trickier than it sounds.
It is, yeah.
So think about this. A study finds that people who own cats are less likely to have heart attacks.
Okay.
Does that mean cuddling Fluffy is preventing heart disease? Well,
that's a good question.
Hold your catnip. Probably not.
Probably not.
That's where understanding causation versus association is key. And luckily, we have a fantastic guide for this. And that is Dr. Hamdi Alhakimi's course, Modern Medical Statistics. He holds an MD, a master's in epidemiology and medical statistics, and a master's in public health.
Wow.
So we're in good hands.
That's impressive.
I know, right?
Yeah.
So this deep dive is actually the first in a series we'll be doing on Dr. Alhakimi's course, sort of breaking down these tricky statistical concepts that are crucial for understanding health research, but often get glossed over in the news.
Right.
You know, they'll
just kind of throw out statistics
and
not really explain what's going on behind them.
Exactly.
Yeah.
So to kick things off, let's just dive right into it. What does causation really mean in health research?
Well, causation means one factor directly leads to a specific outcome, like a disease. But it's not always simple.
Okay.
There are two main types, direct and indirect.
Okay.
Direct causation is pretty straightforward, like, a bee sting causing an allergic reaction. The sting itself is the direct cause.
Okay, that's clear enough. But what about indirect causation?
Sure.
Those seem more common in health, right?
Absolutely.
Especially with chronic diseases.
Yeah. Indirect causation involve kind of a chain reaction. Think of smoking.
Oh, okay.
Leading to lung cancer. The smoke doesn't magically create cancer cells overnight. Instead, it triggers a cascade of biological changes over time, eventually leading to cancer. And as you mentioned, with chronic diseases like heart disease or diabetes, it's rarely one single cause, but a complex interplay of factors.
So if finding a direct cause is like solving a one-step puzzle,
right,
then figuring out indirect causation is like putting together a giant jigsaw puzzle where some pieces might even be missing.
Exactly.
Now let's move on to association.
Okay.
How's that different from causation?
Think of association as spotting a pattern. It's a statistical link between two things.
Okay.
Meaning they tend to occur together, but that doesn't mean one causes the other.
Okay.
It's like noticing that people who carry umbrellas are more likely to be wet.
Right.
Carrying an umbrella doesn't make it rain.
It doesn't make it rain.
No.
But in health, those links can be really confusing, right?
They can be, yeah.
Dr. Alhakimi uses an example that always sticks with me. Can you remind me what it is?
Yeah. He talks about the correlation between children's shoe size and reading ability.
Oh, right.
Older children tend to have bigger feet and read better, but obviously big feet don't make you a better reader. They're both linked to age, which is what we call a confounding factor.
Right. It's not the shoe size itself. It's
the age.
The age.
Yeah.
That's a great reminder that just because two things show up together, it doesn't mean one causes the other.
Exactly.
There could be other factors at play that we might not even be aware of.
Absolutely.
So how do researchers start to figure out if it's causation or just association?
Well, Dr. Alhakimi highlights 4 types of causal relationships, which can help us kind of think through the possibilities.
Okay.
First, we have necessary and sufficient.
Okay.
This is rare. It means the factor is both essential for the disease to occur and always causes it on its own.
Right.
Think about the rabies virus. Without exposure, you won't get rabies. And exposure almost always leads to the disease.
Okay, so that's
a pretty
very clear cut.
Yeah.
Cause and effect.
Cause and effect, yeah.
Okay, what's next?
And then there's necessary, but not sufficient.
Okay.
This is common with infectious diseases. The factor is needed, but not everyone exposed gets sick. For example, the tuberculosis bacterium needs other factors, like weakened immunity, for it to actually cause the disease.
So it's more like the bacteria creates the potential for the disease.
Right.
But other things determine whether you actually develop it.
Exactly.
Fascinating. What about the third type?
The third type is sufficient, but not necessary.
Okay.
This means the factor can cause the disease on its own, but other factors can too.
Okay.
Think of lung cancer. Smoking can cause it, but so can exposure to radon, and someone could develop lung cancer without either of those.
So there are multiple paths to the same outcome.
Right, exactly.
Making it harder to pinpoint one single cause.
Yeah.
What's the last category?
Finally, and this is the most common, is neither sufficient nor necessary. This means the factor contributes to the disease, but can't cause it alone.
Right.
And the disease can happen without that factor. A lot of chronic diseases, like heart disease, fit here as it's a web of genetics, lifestyle, and environmental factors.
That last type sounds especially tricky to unravel, especially if researchers are trying to tease apart those individual threads.
Like a big tangled knot.
Now, I know there's a specific tool that researchers use when they're trying to figure out if there's a true causal link. Can you tell me more about the Bradford Hill criteria?
Absolutely. Imagine it as a detective's toolkit for investigating cause and effect. Dr. Alhakimi dives deep into each of the 9 criteria, which we'll walk through. They act as a checklist to assess the strength of evidence pointing to a causal relationship. And they're really helpful for understanding complicated health issues.
Okay, I'm ready to play detective.
All right.
Let's start with the first one, which I believe is called strength of association. What does that mean?
Sure. Strength of association basically means that a strong link between a potential cause and an effect lends more weight to a causal relationship. One very strong example is smoking and lung cancer.
Right.
The association is so strong, it's hard to dismiss.
Right. The stronger the link, the more likely it is that there's some cause and effect going on.
Exactly.
Okay, what's the next clue in our detective toolkit?
Next up is consistency. This means that the association is observed repeatedly in different populations, in different settings, and in different studies. So if you have, different researchers conducting separate studies and they all find the same link, it strengthens the case.
So it's like getting confirmation from multiple sources.
Exactly.
The more consistent the findings are, the more likely they are to be pointing in the right direction. Okay, what's next?
Specificity is next, and it's a bit trickier, especially with complex health issues, but it means a specific cause is linked to a specific outcome. An example is asbestos exposure and mesothelioma, which is a rare type of cancer almost exclusively found in people who have been exposed to asbestos.
So the more specific the link, the less likely it is that it's due to just chance or some other hidden factor.
Right.
Okay. Now, what about temporality? That one sounds pretty important.
Temporality is absolutely crucial. It's arguably the most important criteria. What it means is that the cause must happen before the effect. So, for example, imagine researchers investigating if a certain food caused an outbreak.
Right.
They would need to show that people ate that food before getting sick, not the other way around.
Right. That seems pretty obvious.
Yeah.
But I can see how it could get tricky in some studies, especially if they're relying on, people's memories of things.
Exactly. Yeah, that can be a big problem.
Okay. What's next?
We then have biological gradient, which is also known as the dose-response relationship. And this basically looks for a clear pattern. As exposure to the potential cause increases, the risk of the outcome also increases. So think about sun exposure and skin cancer. More sun, higher risk.
So it's like turning up a dial. The more you're exposed to the potential cause, the stronger the effect.
Yeah, like a dimmer switch.
Okay. Now, what about plausibility?
Plausibility just means that there's a biologically believable explanation for how the cause could lead to the effect.
Right.
So we know that viruses invade and damage cells.
Right.
So it's plausible that a virus could cause certain symptoms or diseases.
Okay, so it has to, make sense.
It has to make sense.
Scientifically. Yeah. Okay, what about coherence? That one kind of sounds similar to plausibility.
Yeah, they are related. Coherence means that the proposed cause and effect relationship fits with what we already know about the disease. So if a finding contradicts well-established science, it raises a red flag. Right. And it requires more investigation.
So it's like making sure that the new evidence fits into the existing puzzle, not creating a completely different picture.
Exactly.
What about experiments?
Experimental evidence, often from randomized controlled trials, is strong evidence for causation. So in these trials, participants are randomly assigned to receive either the potential cause, like let's say a new drug, or not. And this really helps to eliminate bias and isolate the true effect.
So it's the closest we can get to a controlled environment where we can really see if changing one thing leads to a change in something else.
Exactly.
Okay, what's the last criterion.
Finally, we have analogy.
Okay.
Which means looking for similar cause and effect relationships in other areas.
Okay.
So, for example, if we know that one drug in a certain class causes a specific side effect, we might suspect that other drugs in that same class could also cause that side effect.
So it's about using what we already know to kind of make educated guesses about new situations.
Exactly.
Now, I remember you saying that we don't have to check off all 9 of these criteria.
That's right.
To have evidence for causation. Can you explain that a little bit?
Yeah, absolutely. It's not really a checklist.
Okay.
It's more like weighing evidence on a scale.
Right.
Some criteria are more important than others. Like we said, temporality is really important.
Right.
And the overall strength of the evidence matters most.
Gotcha.
And even with all 9 criteria, causation is very rarely black and white, especially in health, where things are so complex.
That makes sense. It's like putting together all the pieces of the puzzle.
Exactly.
And seeing what picture emerges, even if we don't have every single piece.
Yeah, you got it.
Now, in the real world of health research, there are a couple of kind of sneaky culprits that can really kind of mess with those puzzle pieces.
Absolutely.
And that's confounding and bias. Can you tell us a little bit more about those?
Sure. They're like illusions that can distort the picture.
Okay.
Confounding is when a third factor is related to both the potential cause and the outcome.
Okay.
Making it seem like there's a link between them when there really isn't.
Okay, that's like our ice cream and drowning example that we talked about earlier, where hot weather was the real culprit, not the ice cream itself.
Exactly. Yeah, and researchers need to account for these confounders,
right? Which
can be tricky.
Right.
But they can use strategies like randomized controlled trials where participants are randomly assigned to groups, or they can use statistical techniques like regression analysis to adjust for these hidden factors.
So regression analysis helps to kind of filter out the noise so you can see the true signal.
Exactly.
Okay, what about bias?
Bias is any systematic error in a study that can lead to wrong conclusions.
Okay.
And there are many types of bias, like selection bias, for example, which happens when study participants aren't representative of the population that they're supposed to represent.
Oh, okay. So if you're studying exercise habits, but you only recruit volunteers from a marathon,
right,
your findings might not apply to the average person.
Exactly, yeah. And then there's recall bias, which is common in studies that rely on people's memory. People with a specific health issue might be more likely to remember past events related to it.
Right.
And that can skew the data.
So if you're studying headaches, people who have a lot of headaches might remember more childhood head bumps.
Exactly.
Than people who rarely get headaches.
Exactly. Right. And then there's observer bias, which is where the researcher's expectations actually influence how they collect or interpret the data, even unconsciously.
So they're kind of seeing what they want to see.
Exactly.
Even if it's not really there.
Yeah. It's like seeing patterns in the clouds.
How do researchers deal with all these potential biases?
Yeah. Well, Dr. Alhakimi emphasizes having clear study protocols for every step of the research process.
Okay.
From recruiting participants to analyzing the data. This helps to reduce subjective interpretation and keep things consistent.
So it's like having a detailed recipe to follow.
Yeah.
So everybody's baking the same cake.
Exactly. Yeah, and blinding is also really crucial.
Okay.
This means keeping certain information hidden, like who's getting the real treatment and who's getting the placebo, to prevent expectations from swaying the results.
So like a taste test.
Exactly.
You don't know what
you're trying
so your preferences don't influence your judgments.
Right.
Are there any other ways to minimize bias?
Transparency is really key.
Okay.
Researchers should be upfront about their methods and any potential limitations of their study.
Okay.
Allowing others to critically evaluate the findings.
So it's about acknowledging that no study is perfect.
Right.
But by being open about the potential flaws,
exactly,
we can better understand the results.
Yeah.
Now, this might sound like a lot of kind of, inside baseball for researchers.
Yeah.
But why should we as, everyday consumers of health information care about all this?
Because we are bombarded with headlines about new studies and health advice all the time.
All the time.
And understanding confounding, bias, causation, and association helps us to be more savvy consumers of this information.
Right.
So we're not just blindly accepting whatever we read.
So it's about developing our own BS detector for health news.
Yeah.
What advice does Dr. Alhakimi give for being, more critical consumers?
He encourages us to ask questions like, who did the study?
Okay.
Who funded it?
Mm-hmm.
Were there any potential conflicts of interest?
Right.
Was it a randomized controlled trial, which is considered the gold standard?
Right.
Or was it an observational study, which might be more prone to those confounders and biases that we talked about?
That's great advice.
Yeah.
Just because a study is published, it doesn't mean it's flawless.
Absolutely.
Or that the findings are definitive.
No.
What else should we watch out for?
Pay attention to the language that's used.
Okay.
Are they making grand claims about curing or preventing something? Or are they using more cautious language about associations and potential benefits?
Right.
And remember, if it sounds too good to be true, it probably is.
Right.
Health research is complex.
Yeah.
And simple answers are very rarely the whole story.
This has been eye-opening. It's like getting a crash course in how to think critically about
I hope so.
health research.
Yeah, me too.
And if you're really interested in diving deeper, Dr. Alhakimi's Modern Medical Statistics Course is just a treasure trove of information.
It is, yeah.
It's a really great way to build
A strong foundation
for understanding medical research.
Mm-hmm.
We've covered so much ground this part of our deep dive, really unpacking those tricky concepts of confounding and bias and learning how to be more critical consumers of health information. Welcome back to the final part of our deep dive into causation and association in health research. It's amazing how much ground we've covered with Dr. Alhakimi's Modern Medical Statistics Course as our guide. We've learned about those sneaky confounders and biases that can lurk in studies, explored the Bradford Hill criteria, and started thinking like detectives when we see health news. Now, let's put all this knowledge into practice. I'm really curious to see how these concepts apply to real-world situations. Where should we start?
Well, let's tackle one of the hottest topics out there, nutrition.
Okay.
Think about those endless headlines about what we should and shouldn't eat.
Right.
It can feel like every day a new study contradicts the last.
I know.
Coffee prevents cancer one day, then causes it the next. How can we make sense of it all?
I know what you mean. It's enough to make you want to give up and just eat pizza all day. But Dr. Alhakimi gives us some excellent strategies for sifting through all the noise. What's his main advice?
He stresses the importance of not just reading headlines, but actually digging into the research itself.
Okay.
Let's take the example of dietary fat and heart disease.
Okay.
For decades, the message was that eating fat, especially saturated fat, clogged your arteries and led to heart problems. But as research has evolved, the picture has become more complex.
I've definitely heard that. I remember when fat-free everything was all the rage.
Right.
But now it seems like some fats are okay, maybe even good for you. What changed?
Well, we've learned that not all fats are created equal. Some, like trans fats found in processed foods, do seem to increase the risk of heart disease.
Okay.
But other fats, like the unsaturated fats in olive oil, avocados, and nuts, might actually be beneficial for heart health.
So just saying fat is too broad. It's like saying all fruit is the same when you have apples and oranges. But how do researchers actually figure out which fats are good and which are bad?
That's where those carefully designed studies, the ones that consider all those confounders we talked about, come in. It's not enough to just look at how much fat people eat and whether they develop heart disease. Researchers need to consider genetics, exercise habits, overall diet quality, and so much more.
Right. It makes sense. It's like trying to solve a mystery. You need all the clues, not just one piece of the puzzle.
Exactly.
But even with well-designed studies, Dr. Alhakimi is cautious about jumping to conclusions about causation based solely on observational studies. Why is that?
Because observational studies can only show us associations, those patterns or links between things.
Right.
Even if we find, say, that people who eat a Mediterranean diet have lower rates of heart disease, that doesn't automatically mean the diet caused the lower risk.
There could be other factors we haven't considered.
Right.
Maybe people who follow that diet are also more likely to exercise or manage stress better, which could also contribute to heart health. It's a bit like the chicken and egg dilemma. Does exercise lead to better health, or do healthier people tend to exercise more? It's hard to tease apart.
It really is.
So even with something as seemingly straightforward as diet, there are so many layers to unravel.
Absolutely.
We've talked about food. What about another big lifestyle factor? Exercise. Everyone knows it's good for you. But how strong is the evidence for a true cause and effect relationship between exercise and better health?
Well, there's a mountain of evidence showing a strong association between physical activity and a reduced risk of many chronic diseases. Heart disease, stroke, type 2 diabetes, even some types of cancer.
So that sounds pretty convincing. But is it like a slam dunk case for causation?
While the evidence is strong, it's important to remember that much of it comes from those observational studies we were just discussing.
Right.
They can show us patterns, but they can't definitively prove that exercise itself causes the health benefits.
Because again, there could be other things going on. People who exercise regularly might also tend to have healthier habits overall, which could explain the lower disease risk.
Exactly.
So even with something like exercise, which we generally accept is good for us, there's still room for nuance and critical thinking.
Absolutely.
Now let's switch gears a bit and talk about how these principles apply when we're evaluating new treatments and interventions.
Okay.
What do we need to keep in mind?
This is where randomized controlled trials, those carefully designed experiments we talked about earlier, really come into play.
Okay.
They're considered the gold standard for determining whether a new drug, therapy, or medical device is truly effective and safe.
Because by randomly assigning people to either get the treatment or a placebo, researchers can minimize those pesky confounders and biases.
Right.
Giving us a clearer picture of the treatment's true effect.
Exactly.
Can you give us an example of how that works in practice?
Sure. Let's imagine researchers are testing a new drug for high blood pressure. They would randomly assign participants to two groups. One group gets the new drug, and the other gets a placebo pill that looks exactly the same but contains no active ingredients.
And importantly, neither the participants nor the researchers know who's getting what until after the study is done, right? That's what we call blinding, and it helps prevent expectations from influencing the results.
Exactly. And by comparing the outcomes of the two groups, how much their blood pressure changes, for example, researchers can determine if the new drug is truly more effective than the placebo and if there are any side effects.
Those randomized controlled trials sound like they play a huge role in the approval process for new drugs and therapies.
Absolutely. Regulatory agencies like the FDA in the U.S. rely heavily on the results of those trials to determine if a new treatment is safe and effective enough to be approved for public use.
Right.
It's a rigorous process, but it's there to protect us.
It makes sense. We want to be sure that the treatments we're using are truly beneficial and not causing more harm than good. Wow, we've covered so much ground in this deep dive into causation and association. It's incredible how these concepts, which might seem abstract at first, have such real-world implications for how we understand health, make decisions about our own well-being, and even shape public health policy.
I agree. It's been a fascinating journey through Dr. Alhakimi's modern medical statistics course. We've learned that unraveling the mysteries of cause and effect in health is a complex process, full of nuances and potential pitfalls.
But perhaps the most important takeaway is the importance of critical thinking.
Absolutely.
We've learned to question headlines, dig deeper into the research, and consider all the factors that might be influencing what we see and hear about health.
And for anyone who wants to keep learning and sharpening their critical thinking skills, I highly recommend checking out Dr. Alhakimi's course.
It's a great resource.
It's a fantastic resource for anyone who wants to better understand the world of medical research and become a more informed and empowered healthcare consumer.
That's great advice. So to all our listeners, keep those critical thinking caps on, keep asking questions, and keep exploring the fascinating world of health and science. Until next time.